I'd like to thank the organizing committee for organizing this great meeting, gathering those interested in liver disease, and I hope that this meeting and future meetings will help convince the politicians, the governments, and the health care providers that liver disease is an important cause of morbidity and mortality in our continent. So I'll be talking about the burden of liver disease in North Africa. These are the countries of North Africa: Egypt, where I come from, Libya, Tunisia, Algeria, and Morocco. And I'd like to start with this slide to show you the importance of liver disease in North Africa. This is a slide showing the mortality from liver disease in North Africa. The first column shows the population of the different countries. The population of Egypt is 99 million, Libya 6.5 million, Morocco 36 million, Tunisia 11 million, and Algeria 42 million. The percent of liver mortalities as part of the total mortalities is 10% in Egypt, 2.5% in Libya, 2% in Morocco, 2% in Tunisia, and 1% in Algeria. And the age-adjusted death rate is 84 in Egypt per 100,000, 17 in Libya, 14 in Morocco, 13 in Tunisia, and 6.7 in Algeria. The rank of liver mortality from liver disease among the different causes of death in the country: in Egypt, mortality from liver disease ranks 3rd, in Libya 10th, Morocco 10th, Tunisia 10th, and Algeria 17th. And the rank in the world in terms of mortality from liver disease: Egypt ranks number 1, and soon this will change, hopefully. Libya 81, Morocco 94, Tunisia 102, and Algeria 149. So this shows you the magnitude of liver disease and mortality from liver disease in North Africa. And the most common causes of mortality from liver disease, of course, are hepatitis B, hepatitis C, and hepatocellular carcinoma, which is usually due to hepatitis B and hepatitis C. I'll be talking about HCV, then HBV, then HCC, the most important causes of liver morbidity and mortality in the North Africa. So we'll be starting with hepatitis C and the prevalence of hepatitis C in North Africa. The prevalence in Egypt is around 10%. In Libya, it's around 4%. And in Algeria, Tunisia, less than 1%. And in Morocco, about 2%. In Egypt, these are the results of the demographic health surveys conducted in 2008 and 2015. The prevalence of HCV antibody in 2008 was 14.7%. The prevalence of HCV viremia was 9.8% in the age group 15 to 59 years, and this dropped to 10% prevalence for antibody in 2015 and 7% prevalence of HCV viremia in 2015. This drop was probably due to the program of treatment of HCV with interferon and ribavirin, and the adoption of good infection control measures. When you look at the contribution of African countries to the total viremic HCV infections, you will find that among the countries responsible for 80% of the global viremic infections of HCV, there are 11 African countries. And Nigeria ranks 3rd, and Egypt ranks fourth. So what did we do in Egypt to decrease this high prevalence, or to attempt decreasing this high prevalence of HCV? We started a national program for the treatment of hepatitis C in 2006 through 26 specialized treatment centers all over Egypt. 360,000 chronic HCV patients were treated with pegylated interferon and ribavirin for 48 weeks during the period of 2006 to 2014, with an SVR of approximately 50% and the cost of treatment per patient of $2,000 US, and an annual budget of $90 million. Nowadays, we have different combinations of interferon-free, directly acting antivirals that achieve a cure rate from hepatitis C of 90 to 100%. So the policy changed and the treatment protocols changed in Egypt. And starting October 2014 to May 2015, SOF plus pegylated interferon plus ribavirin was used in interferon-eligible patients, and SOF ribavirin for 6 months were used in interferon-ineligible patients. In May 2015, Simiprevir was introduced, and the regimen changed to SOF, interferon, and ribavirin for interferon-eligible patients, and SOF Sim for interferon-ineligible patients. And since January 2016 until now, the regimen used is interferon-free, consisting of SOF plus daclatasvir for all patients, and all patients are treated irrespective of their fibrosis stage. Scaling up the national program was done through making DAAs more available, negotiating reduced prices, fast-track registration, encouraging local production of generics, increasing the treatment centers from 26 to 100 all over Egypt, training more healthcare workers to cope with the increased flow of patients being treated, and capacity building for data management in these centers. The number of cases treated annually increased from 65,000 to 400,000. And actually what happened is that because we were treating so many patients, we started running out of patients. And that's where the screening program started to step in to gather patients so that we can achieve our target of treating most of our patients with HCV. Who's paying for the treatment? The government is paying for the treatment in 83% of the patients, the health insurance in 9%, and those who pay out of their own pockets, 8%. The cost of treatment, the monthly cost of SOF plus DAC or LEDI is around $25 US. So what's our forecast for 2030 in Egypt? We discussed several scenarios for the treatment of HCV in Egypt. And the scenario we started to adopt was the scenario 2, where we plan to treat 325,000 patients per year. Actually, we exceeded that target. And treating them with interferon-free DAAs with a success rate or an SVR rate of 90% or more, and treating all patients infected irrespective of the fibrosis stage, together with prevention measures of new infections. If we achieve these targets, by 2030, we're going to get a 95% reduction of the total of infected HCV patients, an 88% reduction of patients with compensated cirrhosis, an 87% reduction of patients with decompensated cirrhosis, an 85% reduction in patients with HCC, and a 77% reduction in patients with HCV-related mortality. Adopting this scenario will result in 4,150,000 fewer viremic individuals in 2030. By 2025, the viremic prevalence drops to 2%. By 2030, the viremic prevalence will be estimated at 0.4% in Egypt. Between 2013 and 2030, 1.7 million new infections will be avoided, and 240,000 HCV-related mortalities will be prevented. This will be feasible if DAAs are available at an affordable price to be able to treat the necessary numbers, increasing the diagnosis of new cases and preventing new infections, and we already accomplished all these targets. It is very important to note that part of this strategy is to prevent transmission of disease. If we do not do preventive measures together with the treatment measures, we're going to get only a 79% reduction of the totally infected cases by 2030, compared to a 95% reduction if we adopt preventive measures with the screening and the treatment of patients. So this is HCV and a success story in the management of HCV in Egypt. What about hepatitis B virus? This is the prevalence of hepatitis B surface antigen estimates for 2016 for all ages. And in North Africa, the prevalence is around 1%, except for Tunisia, where the prevalence is around 3%. This is the hepatitis B surface antigen prevalence estimates in 2016 in children aged 5 years. This is very important because this reflects the success of vaccination programs. And you can note that in Africa, you still get the colors of high prevalence, indicating that there is something wrong with the vaccination or the preventive measures in infants and children. This is an estimate of the magnitude of the problem of HBV in the North African countries. The prevalence of HBV in Egypt is 1%, in Libya it's 1.5%, in Morocco 1.1%, in Tunisia it's 3.9%, and Algeria 1.5%. I'd like to draw your attention to two columns here. The first is the percentage of diagnosed cases of HBV. The percentage ranges from 3 to 39%. So most of the cases of chronic HBV are not diagnosed. They don't know that they have chronic HBV. The second column is this column, the percentage of treated patients over the treatment eligible. And look at the very low figures of those that have received or being treated for HBV. 1% in Egypt, 2% in Libya, 16% in Morocco, 2% in Tunisia, and 1% in Algeria. So most of the HBV patients are actually not receiving treatment for their infection. The coverage with the 3-dose infant vaccines is quite good in the North African countries, but the timely birth doses are only good in Libya and Tunisia, quite low in Egypt, Morocco, and so we need to scale up these birth doses in these countries. And this is the global and regional HBV cascade of care in 2016. Again, I'd like to draw your attention that out of those chronic HBV infections who are eligible for treatment, only 5%, an average of 5%, receive antiviral treatment. Out of those patients with chronic HBV infection, only 20 to 30% are diagnosed worldwide. This is the proportion of all infants who received 3 or more doses of the HBV vaccine. In Africa, it's around 80%, a good coverage, but the proportion of all infants who received timely birth dose within 24 hours of birth is very low, about 10% in Africa. So this needs to be scaled up. The proportion of all infants born to hepatitis B surface antigen mothers who received HBV immunoglobulin, timely birth dose, and at least 2 more doses of the vaccine, in Africa, none, almost 0, because the introduction of HBV immunoglobulin in Africa is so difficult due to the cost. And this is the proportion of mothers with high viral load who received peripartum treatment with antivirals to prevent mother-to-child transmission. Again, in Africa, a very low percentage. In Africa, even North or Sub-Saharan Africa, the mothers are usually not screened for HBV, and most of the viremic mothers do not receive treatment for their infection. This is an illustration of the global coverage of the HBV vaccine at birth, and in Africa, a few countries adopt this strategy, namely North Africa, Libya, Tunisia, Algeria, and Morocco. In Egypt, we started introducing the HBV vaccine birth dose, and hopefully in the next few years there will be good coverage of this birth dose. So we still have a problem with chronic hepatitis B. To achieve 90% reduction in new chronic infection and 60% reduction in mortality, you need to scale up coverage of infant vaccination to 90%, scale up birth dose vaccination to 80% of neonates, use of peripartum antivirals to 80% of HBV E antigen positive mothers with high viral load, and population-wide testing and treatment to 80% of eligible people. So we are still having lots of challenges to face with chronic hepatitis B. What about hepatocellular carcinoma? There is a high incidence of hepatocellular carcinoma. The incidence is 8.9 cases per 100,000 person-years, mostly due to chronic infections with HBV and or HCV. HCC is diagnosed at an earlier age, median of 45 years, and at more advanced stages than the rest of the world. And HCC is the leading cause of cancer-related mortality in many African countries. This is the estimated liver cancer mortality in men worldwide. And look at the colors in Africa. All the liver cancer mortalities are in the high range from 5.4 to more than 12.7. So still we are having a great problem in Africa. with liver cancer mortality. This is a very interesting study, a retrospective study of hepatocellular carcinoma cases from 9 countries. One of them was Egypt, representing North Africa, the rest from sub-Saharan Africa. The interesting point in this study is that when they studied the characteristics of HCC in these African countries, we found that the characteristics were quite different in Egypt, representing North Africa, compared to the sub-Saharan Africa. The age at diagnosis of HCC in Egypt was 58, the median was 58. In the sub-Saharan African countries, it was 46, so the age was significantly lower in sub-Saharan Africa. The etiology was HCV in Egypt. The main etiology in sub-Saharan Africa was HBV. And the stage of hepatocellular carcinoma was more advanced in the cases diagnosed in sub-Saharan Africa. Multinodular hepatocellular carcinoma was present in 84% in cases from sub-Saharan Africa compared to 46% in Egypt. The size of the tumor was bigger in cases diagnosed in sub-Saharan Africa compared to cases diagnosed in Egypt, and the presence of extrahepatic spread was more in the cases diagnosed from sub-Saharan Africa compared to Egypt. So the conclusion is that cases diagnosed in sub-Saharan Africa compared to cases in North Africa are at a younger age and the more advanced liver disease, and mostly due to HBV compared to HCV in North Africa. Another important point is that the treatment offered to those patients with HCC was there was much more availability of treatment options in Egypt and North African countries compared to sub-Saharan Africa. The percentage of patients treated in sub-Saharan Africa was very low, probably due to the advanced liver disease, probably due to the advanced tumor stage, and to unavailability of the different treatment options. This was reflected on the survival of HCC. Survival of HCC in Egypt was better than that in sub-Saharan Africa. So I'd like to end this presentation with this slide. Can the heavy burden of liver disease in Africa be controlled? Definitely it can, but we have many challenges. The introduction of new treatments is usually slow in Africa. You have to negotiate affordable prices. You have to convince the governments to pay for the treatment. You have to overcome administrative constraints. You need fast-track registrations of new medications. You have challenges in diagnosis. The number of diagnosed individuals needs to be increased considerably through screening programs. The strategy should emphasize efforts to increase awareness and testing for HCV and HBV, and you have to prevent stigmatization. In addition to the effect of treatment, active prevention is necessary, especially in healthcare settings. You have to scale up birth dose vaccination to 80% of the neonates, and you have to treat pregnant females with high viremia, and there has to be punitive legislation for disease transmission. Thank you very much.